Respected audience, Assalamu alaikum. I am Professor Shamsuzzaman, Professor of Pathology. I welcome all in today's 36th lecture on systemic pathology. Today, day 6 of diseases of cardiovascular system. Dear audience, in 35th lecture, that is in day 5 of diseases of cardiovascular system, I have told you about the myocardial infarction, and briefly I have stated about the definition of ischemic heart disease, types of ischemic heart disease, definition of myocardial infarction, pathogenesis of myocardial infarction, causes of coronary arterial occlusion associated with myocardial infarction, and different morphological changes in myocardial infarction. Today's topic is laboratory diagnosis of myocardial infarction and complications of myocardial infarction. Laboratory diagnosis of myocardial infarction and complications of myocardial infarction. First, come to laboratory diagnosis of myocardial infarction. Dear audience, if anybody come to you with myocardial infarction, what laboratory investigations is done for myocardial infarctions? Investigations are ECG, troponin I, routine blood examination, estimation of enzymes, echocardiogram. So, if anybody come to us with myocardial infarction, in the laboratory we have to do ECG, troponin I, routine blood examination, estimation of enzymes, echocardiogram. First, come to troponin I. Troponin I is a protein present in cells of myocardium. When the myocardial cell undergo necrosis, it comes out and blood level of troponin I is increased, and high titer of troponin I is found in myocardial infarction. Troponin I is a protein. It is present in cell of myocardium. When there is necrosis of myocardium, due to necrosis, of myocardium, what happens? Troponin I comes out of muscle cell. Troponin I comes out in blood from the muscle cell, and there is increased blood level of troponin I. Increased level of troponin I in blood. Again, troponin I is a protein. It is present in cell of myocardium. When there is necrosis of myocardial cell, troponin I comes out in blood, and the titer of troponin I is increased. In myocardial infarction, high titer of troponin I is obtained. In myocardial infarction, high titer of troponin I is obtained. Dear audience, there are two types of troponin. One of them is troponin I. This troponin is important, so it is called troponin I, and I stands for important. Again, there are two types of troponin. One of the troponin is troponin I, and this troponin I is important, and this I stands for important. Now come to routine blood examination. Dear audience, even if it comes to you with myocardial infarction, we have to do routine blood examination. Total leukocyte count, we will get leukocytosis. Dear audience, you know myocardial infarction is associated with acute inflammation in the myocardium. As it is acute inflammation, there will be leukocytosis. We have to do differential leukocyte count. If we do differential leukocyte count, in case of myocardial infarction, we will get predominance of neutrophil. Predominance of neutrophil. Dear audience, you know myocardial infarction, there is acute inflammation, and neutrophil is the acute inflammatory cell. Now come to another investigation, estimation of enzymes. Enzymes are CKMB, creatinine, kinase MB, AST, the former name is AGOT, LDH, lactic dehydrogenase. So, estimation of enzymes, creatinine kinase MB, AST, LDH. CKMB, creatinine kinase MB. Within 4 to 8 hours of myocardial infarction, CKMB blood level is elevated above the baseline within 4 to 8 hours of myocardial infarction, CKMB level is elevated above the baseline. So if anybody comes to you with myocardial infarction, within 4 to 8 hours of myocardial infarction, the blood level of CKMB above the baseline is elevated, and peak level of CKMB at 24 hours of myocardial infarction. The peak level of CKMB is obtained within 24 hours of myocardial infarction, and this peak level declines to the baseline within 4 days. Within 4 days, peak level of CKMB falls to baseline. So within 4 days, elevated level of CKMB falls to baseline. Dear audience, so for recent case of myocardial infarction, among the enzymes, CKMB is important. AST in myocardial infarction, AST level is elevated. It is elevated in myocardial infarction. Now come to LDAs. Lactic dehydrogenase. Lactic dehydrogenase is elevated after 24 hours of myocardial infarction. LDAs is elevated after 24 hours of myocardial infarction, and peak level of LDAs is obtained within 3 to 6 days. Peak level of LDAs is obtained at 3 to 6 days of myocardial infarction, and the peak level of LDAs falls within 2 weeks. Peak level of LDAs falls within 2 weeks. Dear audience, for old myocardial infarction, estimation of LDAs is important. Dear audience, LDAs1 and LDAs2 ratio is important for myocardial infarction. LDAs1 and LDAs2 ratio is important for myocardial infarction, and LDAs1 is to LDAs2 is above 1 in myocardial infarction. Again, the ratio between LDAs1 and LDAs2 in case of myocardial infarction is above 1. Dear audience, Again, we can recapitulate. For recent myocardial infarction, creatine kinase MB enzyme is important, and for old myocardial infarction, LDS is important. Dear audience, we are talking about laboratory diagnosis of myocardial infarction. We have to do ECG, we have to do troponin I. Troponin I is a cardiac protein. It is present in the muscle fiber of the myocardium. When there is necrosis, it comes out in the blood and blood level is increased. So we get the high titer of troponin I in myocardial infarction. Then we have to estimate the enzymes like creatine kinase MB, AST and LDAs. In recent myocardial infarction, creatine kinase MB is important because within 4 to 8 hours it is elevated in blood. And for old myocardial infarction, LDS is important because it is elevated after 24 hours of myocardial infarction and it persists for a long time. The ratio between LDS1 and LDS2 is important for myocardial infarction, and the ratio is obtained in myocardial infarction is more than 1. Now come to complications of myocardial infarction. Complications of myocardial infarction. Cardiac arrhythmia, cardiogenic shock, left ventricular failure and pulmonary edema. Rupture of chorda tendini, rupture of papillary muscle, rupture of ventricular septum, thrombus formation, pericarditis. So, the complications of myocardial infarction: cardiac arrhythmia, cardiogenic shock, left ventricular failure and pulmonary edema, rupture of chorda tendini, rupture of papillary muscle, rupture of septum, thrombus formation in heart chamber, pericarditis. First come to cardiac arrhythmia. Dear audience, in myocardial infarction there is localized ischemic necrosis in the myocardium. As there is necrosis within myocardium, there is arrhythmia, and this is cardiac arrhythmia. And cardiac arrhythmia is threatening for life. Cardiac arrhythmia is threatening for life. Cardiogenic shock. Dear audience, we know widespread systemic hypoperfusion of tissue due to disparity between cardiovascular system and blood volume that may threaten life is known as shock. So, in shock there is hypotension, in shock there is decreased effective circulating blood volume, decreased effective circulating blood volume in shock. Dear audience, in myocardial infarction there is necrosis. As there is necrosis, the power of contraction of heart is diminished. As the heart become weak, it cannot pump blood effectively. So, there is decreased effective circulating blood volume and it may lead to shock, and this is cardiogenic shock. In cardiogenic shock, there is no decrease in total blood volume, but as the heart is weak to pump the blood, so there is effective circulating blood volume is decreased. So, there is shock. It is cardiogenic shock. Left ventricular failure and pulmonary edema. Dear audience, we know virtually all or almost all myocardial infarction occurs in the left ventricle. So, as there is ischemic necrosis, myocardial infarction in the left ventricle, the left ventricle cannot contract properly. So, there is chance of left ventricular failure. If there is left ventricular failure, what will happen? If there is left ventricular failure, the cardiac output will be decreased. As there will be decreased cardiac output, there will be accumulation of blood in the lung. As there is accumulation of blood in the lung, there is chance of development of edema in the lung, and this is known as pulmonary edema. Dear audience, as there is accumulation of blood in the lung capillary bed, so there will be increased hydrostatic pressure, and due to hydrostatic pressure there will be transudation, and due to transudation there will be accumulation of fluid in the lung, that is pulmonary edema following left ventricular failure. As there is necrosis in the myocardium, there is chance of rupture of the chordae tendineae. As there is necrosis in the myocardium, chance of rupture of the papillary muscle. As you know, most of the myocardial infarctions occur in the left ventricular wall, including the septum, including the interventricular septum. As interventricular septum undergo necrosis, there is chance of rupture of the septum. Thrombus formation in left ventricular cavity. In left ventricular cavity. Thrombus formation in left ventricular cavity. Dear audience, if anybody suffers from myocardial infarction, there is chance of mural thrombus in the ventricular cavity. You know, there are many types of thrombus: mural thrombus, occlusive thrombus, correlline thrombus, propagating thrombus, consecutive clot thrombus, etc. If the thrombus is formed in the heart chamber or in the blood vessel, it is known as mural thrombus. And you know, for thrombosis, varcostride is needed, and it includes endothelial injury, changes in vascular flow, and changes in coagulability of blood. If anybody suffers from myocardial infarction, there is necrosis of the myocardium. So, there will be endothelial injury, that is endocardial injury. As there is endocardial injury, there is chance of aggregation of platelet. As the heart is weak due to necrosis, it cannot pump blood, so there will be stasis. At the same time, there will be secondary hypercoagulability of blood. Again, if anybody suffers from myocardial infarction, we can get their varcostride, endocardial injury, stasis of blood due to weak heart following necrosis, and due to release of factors there will be hypercoagulability of blood. So, there is chance of formation of thrombus within the heart chamber, and this thrombus is nothing but mural thrombus. So, formation of mural thrombus in heart chamber. Dear audience, as pericardium part and parcel of heart wall, anybody suffers from myocardial infarction, there is chance of pericarditis, So, the complications are cardiac arrhythmia, cardiogenic shock, left ventricular failure and pulmonary edema, rupture of chordae tendineae, rupture of papillary muscle, rupture of interventricular septum, mural thrombus formation in the heart chamber, pericarditis. Dear audience, today I have told you about the laboratory diagnosis of myocardial infarction and complications of myocardial infarction. Among the laboratory diagnosis, ECG, troponin I, routine blood examinations, estimation of enzymes, echocardiogram, and these are the complications of myocardial infarction. Dear audience, today up to this, thanks all.